Thanks very much, Carol. And for those of you who were here for Mari's fantastic presentation before, I think you'll find this is quite different. This is quantitative research, so very much looking at outcomes, although around a similar kind of subject about choice and control over mode of birth in this case. So the aim of this research was to compare the intended and actual vaginal birth after caesarean section, or VBAC rates, at one hospital before and then after the... Oh, I'm sorry. Is that better? How's that? Yeah, is that better? Sorry. So we were comparing intended and actual VBAC rates at one hospital before and then after implementation of a midwife-led model of antenatal care for women with one prior caesarean section and no other risk factors. So a little bit of background first. As we all know, safely reducing the caesarean section rate is an international priority. And in this country, 1 in 10 women who are accessing maternity services have previously birthed by caesarean section. And of all the caesarean sections that we do, a third are performed on women who've previously birthed by caesarean. So focusing our attention to reduce the section rate on this group of women is worthwhile. For the majority of women in that group, VBAC is considered to be a safe and viable option. And actually the short-term health risks to mother and baby of either mode of birth, so VBAC or the alternative elective repeat caesarean section, are considered relatively low. But actually emerging evidence about perinatal epigenetics, about the vaginal microbiome, points to the really protective effect of labour and vaginal birth against long-term conditions like asthma and diabetes and obesity. So perhaps the evidence for vaginal birth has never been stronger in terms of the health benefits. But to date, no effective interventions to increase the VBAC rate have actually been discovered. And what we know from the women themselves, lots of qualitative research into women's experiences, is that the organisation of care that they receive in their next pregnancy, and actually the very health professional who's providing it, can make a real difference to their decision-making process, but also that final decision. So why midwife-led care? Well, as you all know, midwife-led care works on the premise that pregnancy and birth are normal life events. It doesn't just focus on the physical, but also on the social and emotional factors that affect pregnancy, birth, and beyond. And consecutive Cochrane reviews have actually showed that midwife-led care for a low-risk group of women is safe and can confer benefits to the women and also to maternity services. But what's important to note is that within the meta-analyses that led to those Cochrane conclusions, there was a significant proportion of women who have actually previously birthed by caesarean section. So when you're considering the antenatal care of women who've previously birthed by caesarean and the support that they need to make a mode of birth decision, 6 discrete elements of care came to light, and I won't read them out because I don't have time, and I'm sorry for those at the back who can't read them, but just be assured you'll know what they are, because these are actually elements of care that midwives are hugely experienced in, and I would say experts in delivering. So if we can get multidisciplinary support, and if we can have really clear lines of communication and clear lines for referral, then why not have midwives as the lead clinicians for women with one prior caesarean section and who have no other risk factors? And it was with that question in mind that that very model was implemented at a large maternity unit on the south coast of England, and you can guess which one it was. Consultant midwives had developed the innovation, but it had full multidisciplinary support, and that was really important. Workshops were developed for all midwives to build on their experience and to really give them the confidence, the knowledge, the tools and the support that they needed to be the lead carers for women with a prior caesarean section and no other risk factors. And we implemented in 2009 to 10. So this graphic, again, I'm sorry for those at the back who can't see, but hopefully you can kind of make out the colours at least. It's just really to help you visualise the model of care and how it might be different from the traditional obstetric model of care, and actually how it might be different from the model of care for women with a previous caesarean section that you might have in your unit, because I know a lot of units have slightly different models of care. The top row is 2008. That's the traditional obstetric-led model. The bottom row is 2011, and that's the midwife-led model. The yellow boxes that only exist on the top row, for those who can't see, they're the obstetric appointment boxes. So the appointments where the woman would come in to see the obstetrician in the hospital antenatal clinic. And the green boxes, which are the rest, they are the midwife community appointments, so done in a community setting where the midwife routinely sees her community midwife. The boxes with the asterisks, which actually on the top row is just the yellow boxes, on the bottom row it's every single box, is the appointments where within the routine schedule of antenatal care, a mode of birth discussion is recommended. We also recommended in the midwife-led model of care that we had 2 birth planning appointments, so one slightly earlier than normal at 28 weeks and another at 34, compared to the usual 36 week in the obstetric-led model, and then the final birth decision to be made at about 36 weeks in both models of care. And then finally, the solid blue line across the top and the bottom, that's just really to denote the length of time from the very first discussion about mode of birth and the mode of birth decision. So on to this research. As I said, this very different from Mara's. This was a quantitative piece of research, and it was a retrospective cohort study, so comparing those 2 groups, the group who gave birth in 2008, before the implementation, and those who gave birth afterwards in 2011. The primary outcomes were intended and actual mode of birth, and the inclusion criteria for the research was exactly the same as the inclusion criteria for women receiving midwife-led care within the trust. So that was women with 1 prior lower segment, confirmed lower segment caesarean section for a non-recurrent reason, and who had no other medical, obstetric, social or psychological risk factors that would otherwise lead to referral to an obstetrician at booking. The data were collected directly from medical records, and the data were analysed using appropriate statistical methods on an intention to treat basis, and I'll explain a little bit more about that in a moment and why that was important. So the results, we had complete data sets for 405 women. In 2008, all of the women who were in that group, they received the traditional obstetric-led antenatal care. And in 2011, all of the women in that group commenced on the midwife-led care pathway. And throughout their pregnancy, about 20% were referred for obstetric care. And that was for a variety of clinical reasons, but also for the women who'd made an informed choice to choose an elective caesarean section. But importantly, all of the women in the 2011 group, regardless of whether they were referred to obstetric-led care during the pregnancy, they were analysed on the midwife-led care group, so as not to skew the data to include in the obstetric-led group more women who had complications. So moving on to the results and the maternal characteristics. Between the 2 groups, and because it was a retrospective cohort study, it's important to look at the differences between the 2 groups and see whether there were any. And they were pretty similar. No real differences in terms of demographics, social risk factors, or obstetric or medical risk factors. But it was important just to note that when we looked at the indication for the previous caesarean section, there were some differences, which is clinically important. So in 2011, we found that that group had a higher proportion of women who had previously birthed by caesarean because of a baby in a breech presentation, and fewer because of suspected fetal compromise. And as you'll know, the indication for the previous caesarean section can have a real influence on the next mode of birth. So that really justified our decision to include indication for the previous caesarean section in the logistic regression model that we use to account for the confounding factors, the elements that might influence mode of birth. So onto the care that the women actually received. So we compared the antenatal course of care, and we found not surprisingly from the graphic that you've seen, that in 2011 compared to 2008, women saw the community midwife in the community more often. They had fewer appointments in the hospital clinic, they saw fewer different antenatal carers, and they also had a longer time from their first mode of birth discussion to their last, and all of those findings were statistically significantly different. So on to the first of the primary outcomes, intended mode of birth, and we found a higher proportion in 2011, a higher proportion of women opted for VBAC than they did in 2008. 90% for those who can't see in 2011 versus 77% in 2008. And this was one of the primary outcomes, so we did adjust for those factors that might make a difference about mode of birth. So the first one being the indication for the previous caesarean section, whether that was for breech or whether that was for dystocia or delay in the first or second stage. We also accounted for maternal age, maternal BMI, the time since the previous caesarean section, and also the number of previous vaginal births and previous VBACs. And even once we'd done that, we found that the odds of planning a VBAC, having had midwife-led care, was over 2.5 times that of planning a VBAC under obstetric-led care. With the actual mode of birth, we also found that a higher proportion of women achieved a VBAC in 2011 than those who did in 2008. 61% compared with about 47%. And again, we adjusted for those exact same clinical confounding factors, so those same issues that I listed earlier, and found that in this case, the odds of achieving a vaginal birth were nearly 1.8 times that of in 2008. It was also really important that we looked to the successful VBAC rate, because as you'll know, you could have a really high intended VBAC rate, but the failure rate be higher, and that would actually have safety implications. So we wanted to make sure that that wasn't the case, and it wasn't. In 2011, the successful VBAC rate was over 78%, which is higher than the international quoted average of 3/4. And in 2008, by comparison, it was around 68%. That finding wasn't statistically significantly different. That's important to note. But in terms of proportions, there was a clinically significant difference. I'm just going to rush past these slides because I'm a little short on time, but just really to talk to the safety aspects as well, because safety, although we couldn't have that as a primary outcome just because of the size of this research and our sample size, it was really important that we look to safety, because that will be some of the major questions. Is it safe to provide midwife-led care? And as a proxy measure for antenatal safety, we look to the rates of unscheduled antenatal care. And what we found was that in 2011, compared with 2008, the rates of accessing unscheduled antenatal care via the delivery suite was significantly lower, and also the rate of antenatal inpatient admission was also significantly lower. Something that we really didn't expect to find, and once we looked at the reasons why women were seeking unscheduled antenatal care, was that in 2011, the women in that group were far, far less likely to access unscheduled antenatal care because of threatened preterm labour. And that really wasn't something that we were expecting to find, but something that does fit with the Cochrane review about midwife-led, in this case, continuity models of care, which also found that preterm labour is reduced following those models of care. So in terms of postnatal maternal safety, very, very similar. The only difference really was the length of stay, and that was longer in 2008, probably because of the increased caesarean section rate. Equally, neonatal outcomes were very similar. No major differences in the main outcomes that we look at to assess neonatal well-being. There were no neonatal deaths in this study at all. There was one stillbirth, and that was actually in the midwife-led group. given the size of our sample, over 400 women, and given the rate of stillbirth, especially for women who've previously birthed by caesarean section, we were expecting at least one stillbirth, and chance really would determine which group that would fall in. And it is important to note this study was not big enough to detect significant differences between really rare outcomes like stillbirth or major maternal morbidity. But the overall message is that this model of care appears safe. So on to a little bit about why that might be. So first off, we might look to the major difference between the two models of care, and that is the healthcare provider who is providing it. What we know from qualitative research into women's experiences of making decisions about mode of birth is that even when it isn't explicitly stated, women feel that they can infer from the health professional they're talking to what their personal preference for mode of birth is. And importantly, what women say about that is that once they feel they know that, that really sways them about which way they're going to go with their mode of birth decision. Surveys have shown repeatedly that midwives, compared with obstetricians, have a stronger preference for VBAC and vaginal birth in general. And that could be for any number of reasons, probably their professional experiences, maybe something to do with the philosophical underpinning that attracts certain individuals to certain professions. It's unclear as to why, but the important point is that there is a difference here, and that can make a difference. What we also know is that health professionals can be really swayed by the attitudes within the unit where they're working, and even actually the department within which they're working. So it's also important to note that the 2011 group were working in a time when the trust was really positive about VBAC, about reducing caesarean section rates and promoting VBAC. So it might also be that the midwives and obstetricians were generally just more positive about VBAC in that cohort than they had been previously. And we can also look to the organisation of care. So I mentioned earlier about why midwife-led care, and kind of touched on the focus on normality premise that midwifery-led care has. And that focus on normality is explicit in the conversations that women will have with their midwives, but it's also implicit, and I think the messages that kind of pervade when we are providing care in a certain way are really important. So firstly, women were avoiding high-risk clinical areas. Previously, they will surely have made an association between talking about VBAC and going into the hospital, whether that be to see a specialist midwife or whether that be to see an obstetrician. And that must have made a difference. Now they were having those conversations in GPs' surgeries, in children's centres, or even in their homes. Also, the women were they just generally had longer to make their decision. You know, this was a discussion that was kind of being interwoven throughout their antenatal care, from the very first booking appointment until that 36-week point where they were asked to make a final decision. So they had a whole, on average, 8 weeks longer to think about that from that first professional discussion than they had in the obstetric-led care model. And one of the unexpected findings that we came across was the fact that women seem to be much less likely to experience signs and symptoms of threatened preterm labour. And what we know about preterm labour is that it's associated with anxiety and stress within women. So there is a theory that possibly the midwife-led model of care and the fact that women weren't going to and fro from the hospital, that they just generally felt less anxious and stressed about their pregnancies, and maybe therefore less likely to experience signs and symptoms of threatened preterm labour. So I appreciate that was a real whistle-stop tour of that piece of research, but really just to kind of summarise and conclude, what we found was that the midwife-led model of care was associated with an increase in actual and intended VBAC rates. It appears to be safe, and indeed it seems to reduce levels of unscheduled antenatal care, specifically through the delivery suite and inpatient admissions, and also reduces threatened preterm labour. Now, because of the the methods that we use, the methodology, the research design, we can only attribute association between the midwife-led model and these outcomes. We can't say that one caused the other, but certainly further research is indicated, because the results were, I think, more positive than we'd expected, to perhaps carry out a prospective, maybe even a randomised control trial. That would be ideal to compare the two different models of care. And also, really importantly, and especially kind of thinking about what Mara just said, to talk to the women themselves, to the clinicians providing that care, and find out, you know, what they think might possibly make the difference. So that was it. And I did have some acknowledgements, but really the only one that's important is to the women and clinicians who embraced midwife-led care and let us do this research. So, any questions?